In Uganda, 1 in every 4 girls aged 15 to 19 is already a mother. Adolescents aged between 15 to 19 contribute 17.6% pregnancy-related deaths, 44% of 7,200 annual maternal deaths among females aged between 15 to 24 years, 47% of 297,000 unsafe abortions annually among girls aged between 15 to 24 years. These can be attributable to service points discrimination, limited access to sexual and reproductive health and rights services, unmet family planning need for adolescents aged between 15 to 19 years at 30.4%, lack of youth-friendly services with unfavorable policy environment for sexual and reproductive health and rights. Yet, according to the National Budget Framework Paper for the financial year 2020-2021, only 6.2% was allocated to the health sector, a reduction from the 6.4% that was allocated in the 2019-2020 financial year. Join Action Group for Health, Human Rights and HIV and AIDS for a televised talk show on trends in sexual and reproductive health and rights and health financing from financial year 2018-2019, 2019-2020, 2020-2021, and its implications on access to sexual, reproductive health and rights services for young people on Friday the 28th of August 2020, starting at 11 a.m. to 1 p.m. live on NTV.
Welcome to this live talk show where we're going to be having a conversation about the implications on access to sexual and reproductive health and rights services for young people within the country, taking a look at the financing. Joining me to have this conversation, I am joined by Margaret Happy, who is a policy and budget analysis consultant within the country. Welcome.
Thank you.
I'm also joined by Mr. Richard Kabagambe, the Assistant Commissioner in charge of Budget and Health Financing at the Ministry of Health. Welcome.
Thank you very much.
And lastly, I'm joined by Miss Flavia Chomukama, the Executive Director, Action Group for Health, Human Rights and HIV and AIDS. Welcome.
Thank you.
Now, our conversation this morning, do note you can be a part of it. The hashtag you can use is SRHR Financing Trends in Uganda to be a part of the conversation. Now, as you heard with the statistics that we started with, over 70% of Uganda's population is under the age of 25 years. Now, this 70% is in lack of sexual reproductive health and rights. And when we talk about these rights and services, what are we talking about? Family planning with options and choices, safe conception, maternal health care, safe motherhood, cervical and breast cancer screening, treatment, and things like diagnosis and prevention and treatment of sexually transmitted infections, among so many others. So as we start this conversation, we're just simply going to start off with where we stand when it comes to financing over the years, starting from the financial year 2018, and what has been revealed in a particular report that the Action Group for Health, Human Rights and HIV and AIDS has been able to take a look at and be a part of. So we'll start with you, Flavia, so that you can take us through it.
Okay. Good morning, viewers. I'm Flavia Chomukama, and I work for Action Group for Health. I'm the team leader. I would like to bring us forth from the previous 2 years. We've been conducting budget analysis for looking at the amount of funds government allocates to sexual reproductive health, particularly for young people. And over the years, we see a progressively declining increment in funding for this particular section. And like you say, we have a big number of young people, 70%. And we also do realize that our young people, 1 in 4, by the age of 19, they are actually married. So what are those needs that these young people require to remain healthy and make productive lives? We do realize that there is a gap, and the COVID-19 has even made it worse, because what had been put in place has been again retrogressed by the lockdown and the closure of schools, for instance, is a very, very big gap, because we are seeing currently increasing number of children, young girls, young boys engaging in sex. We are hearing about increasing pregnancies. So we see a boom of pregnancies. There will be a boom of early marriages. There will be a boom of unwanted an abortion, and so looking at the trend and how our government has been allocating resources, if we had not met the need over the last years, the unmet need for family planning for that age group is around 39%. So what happens now that we have had a lockdown? Schools where we were getting information are closed. Health centers, in some places we still have lockdown, so going there is becoming problematic. Transportation has increased in price. We see inflation in most of the commodities that we would require as young people to reach and access services. Of course, a young person is going to be with us. We have the ministry here to share with us what plans ahead are, but we have also engaged Margaret Happy as a consultant to do for us a trend analysis, a comprehensive summative analysis of the 3 years that we have moved within this process. AGA has been doing a lot of advocacy for increased budget. In some places it has worked, but in other places it remains stagnant.
What places has it worked and where has it remained stagnant?
For instance, we have been talking about with other partners around increasing medicines for preeclampsia, and we saw an increase in purchase of commodities for mothers who are pregnant. We have also seen increasing information in the schools, in the communities, because government has allowed us to complement its work. We have also seen there was increasingly awareness and increasing places where adolescents and young people can go for services. So we see progress, but it is not, we are not yet there. We are still limited. And now with COVID, we fear that we're going to have a backlash. And we are hoping that government can actually, after listening to the analysis, rethink the budget. And we are also glad that now those big meetings have ended. Probably some of that money can be translated into services that we are able to reach near our places of abode.
Okay. Well, Richard, we bring you into the conversation from the Ministry of Health. You are the Assistant Commissioner in charge of budget and health financing. And I think you'd be the right person to have a conversation with. One thing that Flavia mentions is that within the statistics that we shared just now, a drop from 6.4% to 6.2% in financing when it comes to sexual and reproductive and health rights within the country. Why?
Thank you, moderator and viewers. I think the issue should not be looked at percentage-wise. We should be looking at the quantity of money, because the budget from the other financial year compared to this financial year has increased. So the quantum of money has also increased irrespective of the decrease in the percentage. But I think the point she's bringing is the issue of where we are in terms of COVID. But I want to assure the public that according to our statistics, the family planning commodities, the budget has been increasing progressively for the last 3 years. In 2018, we had only 14 billion shillings. In 1920, it increased to 19.2 billion shillings. In this financial year, it's actually 25 billion. But when the denominator is 40 trillion, it reduces, of course, in percentage-wise, but the quantum remains high. Now, the worry of running out or shortage in terms of commodities should not worry us too much, because government has got a contingency plan that these commodities are in country and they can take us for the next 6 months. Nevertheless, the challenge we have, which we need to share with the public, is the demand.
Okay.
We have issues on the demand side, where we have also noted with concern some of these commodities expire in our hands, and we also incur a cost to destroy them. So we need to mobilize the population to know that the services are there, and we have a very good model of distribution of these commodities.
Which is?
Today. We deliver them to health facilities, government health facilities, but we have also partnered with the private sector and even PNFPs. These are religious affiliated facilities. So at any point of entry, you can go there and get these commodities. But we need to sensitize our population, and this lies in the hands of all of us. It is not a health issue alone, because education must come on board, local governments must come on board, NGOs must come on board and drum it, and also the press. But at least we have commodities that can push us for the next 6 months. Yes.
Okay.
So,
now,
if I could just ask our commissioner, what happens? Why you deliver those commodities and they expire? What is missing, the missing link to ensuring that people can access these services? I think it is role of government to provide primary health care, and that is practically having information education that is, you know, reaching the communities and the young people. But we do realize that most of the communication we have is not really to these young people, because health centers are very, in most cases, the health facilities we have people by age.
Yes.
And then the young people come and they are being asked, you're pregnant, how could you? Tomorrow they don't come. So what is in place that the government can do to ensure that we have attitudes and practices that actually attract? Because the need is there, definitely. Because once young people start having sex or start relationships even without having sex, they need the guidance. And we do realize that the sexuality education, the sexual education policy or framework is still not yet fully, you know, completed and accepted and disseminated. So Uganda at 50-something, how can we still be lacking in information around these practices? Because the demand is there. People need the services. Where have you let us down as
yes,
government?
I was just about to tell you, do go ahead.
She's partly right, but she's also not looking at, we are not, our sector looks at a comprehensive package. So, and it must be also looking at the law. If you see a 15-year-old child moving into a health center and says, I want this, it is not allowed. But
then this is when we bring in, and I don't know if it ties into the social norms that we have as a country, that there are things we cannot talk about. But when you see statistics that say at this particular age, we have one between 19 to 24, we have, 15 to 19, 1 in every 4 girls is a mother. The statistics reveal that perhaps there's a bigger problem, and even from what we have seen during this lockdown period, although we are slowly easing out of it and uncertain of what tomorrow holds, but it has revealed that there might be a bigger problem within our country. And as a ministry, what are you doing about that?
No, we are trying to engage all stakeholders across the board, mostly the local governments and also the religious leaders. They help us a lot, because there are some districts that are below the expected demand. Even the age where you find a married lady cannot go and ask for those services, even when they are there, because of maybe the tribal or the cultural norms. So it's a long battle, but we have also to appreciate, given what we have gone through for the last 10 years, is that there is progressively increasing demand, okay, though we have not reached where I wanted us to reach. And those are social barriers that you cannot just break in a day or two. Okay. Secondly, there are also some policies I think she's talking about, like the school health policy, which government is at the last tail of it. It is just validating it. So I think when it comes on board, we should be able to see the consumption and the demand meeting the supply side.
Okay, well, as we bring in Margaret into the conversation, you've touched on policy, you've also mentioned law, but you've also mentioned financing. And all these three, even with social barriers, just putting it aside for a bit, all these three, in one way or another, guide what happens next when it comes to the access to sexual and reproductive health and rights within the country. So happy bringing you in. From what you've heard, the remarks from Richard and from Flavia, what do you have to say from the policy side?
Thank you so much, Commissioner and Flavia, for your point of view. Once again, I'm called Margaret Happy. I'm a woman living with HIV, but also a survivor of cervical cancer. So I did the analysis from the perspective of a consumer, someone who utilizes these services. Mm-hmm. I carried out a comprehensive budget trends analysis for the financial year 2018-2019 to the current financial year 2020-2021, with a particular interest in sexual and reproductive health. And when we talk about sexual and reproductive health, I went beyond looking at commodities. I went beyond looking at the laboratory supplies. I had also to look at human resources for health. So it was a real comprehensive analysis. But something that I want to bring to the attention of our viewers, even before I look at the monies, because we also have to look at the policy point of view, is that health sector is very critical in producing healthy and productive population that contribute to the realization of our vision, Uganda Vision 2040. Everything we do it towards that. But also another thing I want to bring to the attention of our viewers is that our budgets for the 3 financial years are in alignment with the National Development Plan. And in this case, I'm looking at the Development Plan 2, but also considering Development Plan 3, the draft Development Plan 3, which is yet to be approved, because the current budget that we have for financial year 2020 and to 2021 was aligned with the National Development Plan 3. So when I looked at the resource envelope for the 3 financial years, because I wanted to establish the trends, I realized that in 2018 to 2019, the financial year 2018 to 2019, we had a projection at 29 trillion, but then it increased to around 39 trillion, and then with the current 2020 to 21, it increased to around 39 trillion. Right, just as the Commissioner said, our budget projection has actually increased. But amidst our budget projection being so high, I was also interested in knowing our domestic contribution by our domestic revenues, which I also realized that it increased, the trend also increased. The outturn for 2018 to 2019 was around 16 trillion, and then 2019 to 2020, 19, and then 2020 to 21 to around 21 trillions. I was interested in knowing the share of the budget allocation for the health sector, because if we are looking at sexual and reproductive health, information, services, but also considering the rights, we need to know how much is allocated to the entire health sector. I realized that the share for the health sector is around, it was around 11% in 2018-2019, and then it dropped to around 7% in 2019 to 2020. Again, it dropped to 5.1% in 2020 to 2021. Whereas Commissioner says we do not need to focus so much on the percentage, but I think it is very important because of the reasons I'm yet to share with our viewers. Beyond that, after knowing the allocation for the health sector, I even went further to look at the overview of the health sector expenditures for the 3 years, because I wanted to know how, I wanted to establish its implication on access to sexual and reproductive health and rights. I realized that specifically for the health sector, the allocation for wage, for instance, it kept dropping. For instance, 2018 to 29, the outturn was around 574 billion. Then it increased, actually, it increased to 621 billion, but it remained stagnant for the current financial year. And that has a lot of implication, because when you look at the current budget and plan, you will realize that the Ministry of Health plans to increase the number of health facilities. For instance, health sector 2. We are moving from 1,693 to around 1,818, and then health sector 3, health center 3, we are moving from 1,000 to 1,094 to around 1,818, and that has a lot of implication in terms of wages. But the wage from the last financial year to the current financial year has stagnated. So in terms of accessing sexual and reproductive health services, it creates a huge concern on how the Ministry of Health or the health sector is going to sustain the health services that that we are yet to extend to all those health facilities. And then the commissioner talked about the commodities. When we talk about the commodities, I wanted to establish that one as well. I did the intra-health sectoral allocation for the 3 financial years, and I wanted to know exactly the allocation for the vote 116, which is the national medical stores. And I realized that the allocation for the national medical stores for 2018-2019, it was around 278 billion, but then it increased in the financial year 2019 to 2020, and then it stagnated. It remained constant for the last financial year and the current financial year. And that one also, I think it has a huge complication. Stagnating funding to national medical stores, it's even going to worsen the stockouts of essential commodities, including the reproductive health commodities, like mama kits, like contraceptives, laboratory supplies, and even the life-saving ARVs. And when I talk about ARVs, for speaking from the perspective of the women living with HIV, being initiated on ART is equivalent to maternal health. Because now we know that when a mother goes for antenatal care for the first time, she'll be tested. And then she will, if she tests positive, she'll be initiated on ART. But looking at the allocation that NMS was given for the current financial year, which is the same as the last financial year, yet the population, the size of the population keeps on changing, and we have even established more health facilities, and we are even upgrading, which comes with a lot of implication. So this is something that needs to be looked at critically. I even went further to analyze the funded and the unfunded gap for commodities. I realized that Kawempe, for instance, Kawempe National Referral Hospital, it has 60% of the unfunded gap for commodities. And yet we know that most people refer to Kawempe Regional Referral Hospital, National Referral Hospital as a women's facility, but it has 69% of the unfunded gap. And then when you move further to the health center twos, which are nearer to the women, nearer to the adolescent girls and young women, the communities, those who really want to access the services from the nearby health facilities, it has the unfunded gap for commodities, which stands at around 62%. That's a huge unfunded gap. And I know it is contributed also by the decline in the external financing for 2019, for 2020 to 2019. Because if I also looked at the trends of the external financing in the health sector, you will realize that there is a huge decline. When you compare the previous financial year and the current financial year, it's very huge, and that is why we are also having this. But also we are having the unfunded gap because of establishment of the new health facilities at Health Center 2s, 3s, and upgrading some from Health Center 2s to Health Center 3s. And when I compared, I also looked at the unfunded gaps for commodities, Health Center 3s. It's at 34%. That's very big. Then to our Kirudu here, National Referral Hospital, it's 47%. So we cannot shy away from talking about these percentages. These percentages have a lot of implication. Then beyond that, I did thorough analysis of vote 014, that is the vote for the Ministry of Health, the past expenditure outturns for it, and I realized that the allocation for vote 02, which is health infrastructure and equipment, it also dropped. And so, and that also has a lot of implication, because the health infrastructure and equipment financing, which dropped by approximately 140,000 billion Ugandan shillings, has a lot of implication in terms of how the ministry will continue financing the ongoing health facility infrastructure upgrade, because we have it in the plan. But given the fact that the vote has gone down, so it creates a question on how we are going to, continue financing it. At the same time, when you analyze the documents very well, especially comparing the current financial year with the previous financial year, you will realize that the ministry has prioritized improvement in infrastructure against investment in primary health care budget, which also decreased, So to me, if we are talking about access to sexual and reproductive health services, we have to look at it holistically, beyond only commodities, but we look at which votes have been highly prioritized and which programs under each vote have been prioritized and the sub-programs that have been prioritized.
Margaret, just to bring in, from all that you have mentioned, to bring in the commissioner into this conversation. I've seen him not, and so has Flavia. But to bring him in, because at this point we are speaking on their behalf. As the ministry, she has highlighted a number of areas where some might have been neglected over others. Percentages that she said you said you shouldn't look at, but she has brought it out and magnified something. What are your comments to what she's just said?
No, I think her comments are, her observations, some of them are true and backed by evidence. But I also want to collect on some few issues.
Go ahead.
One is that the budget for the health sector in 1920 was 1.8 trillion, and this financial year it is 2.78 trillion. So there is an increase. Two is that yes, health is very important, but we are drawing from the same treasury. There is health, education, roads, energy, ICT, all these compete and put their proposals into the same treasury. So if you have, and it cannot exist alone, we are advocating for more funding all the time. But when you also go into the government-wide approach and say, if you have more money in health and you don't have money in education, what type of people will be healthy without education? Will they move without roads, power? All these things are important. So there is reprioritization which government takes charge on, and in most cases, cabinet and parliament decides on who takes what. Now, she brought in a good analysis on infrastructure, money that in infrastructure reduced. Yes, you are very right. But this part of this money that reduced from infrastructure is from the development side. We completed Mulago Hospital, we completed Women Hospital. So when a project ends, that money does not keep in the sector, because much of that money is actually borrowed. So that's why you saw that drop. Nevertheless, we must also appreciate government effort. That in the previous financial year, we had to enhance salaries for medical workers. A doctor used to earn 1.8 million shillings. He's now earning over 5 million shillings. A nurse was earning 300,000. Now she earns over 800,000. That's why the wage bill moved from 200 billion to over 590 billion. And it has stagnated this year because our agreement with the unions is that every after 2 years, we continue increasing until when they are comparable to the region. We would wish our medical doctor here to earn over 12 million shillings, but you cannot do it within one financial year. So you should also appreciate that. And I also liked her analysis on seeing our sector being aligned to both the National Development Plan 2 and also the incoming one, National Development Plan 3. All in all, we agree we have to set priorities. And our priorities this financial year were to upgrade health center 2s to health center 3s. As we speak right now, I think maybe the population will tell us, wherever there is a health center 2, it is now becoming a health center 3. Now, it has implications in 3 ways. One, increase the budget in terms of infrastructure, increase budget in terms of wage, and medicines. So all these things cannot be done in one financial year. No. The other year we did about 120, this year we are doing 64. So, and we are providing a health center 3 every sub-county. So it's a 3-year plan. By next financial year, we shall have all health center 3s finished in the country.
Just to take us back to the conversation, when it comes to sexual and reproductive health rights accessibility, if at all you have mentioned earlier that at this point, yes, the commodities are there, but the people coming to pick them are not there. If we see that we have all these health centers increasing, if we have all these workers who are retained and they have a salary, but this group of young people, which is over 70%, continue to die in maternal deaths. We continue to see that we have more infections of HIV and AIDS, which also puts a load on the workers. It begs the question, where is the priority for the Ministry of Health? Because in one way or another, if the quality of health is actually improved for a young child or for a teenager, then perhaps even the load is reduced for the health worker.
Yes.
Yes.
On that one, I think the issue of maternal health, we still have a challenge there. And we have also advised some other innovative ways. You had even to try bringing in the voucher scheme. And we have also another program called result-based financing that is focusing on the mothers that go or the teenagers that go to the facilities to get the services. And we are seeing results. We are seeing commendable results. So being innovative in that way, I think we should be able to close these gaps that are coming in. But also, you need to note that investment in infrastructure is very, very important. Mothers could go to health center 3. They are in labor. They cannot handle the cases. Information to these young people is also very, very important. And that's what we are focusing on, so that within the next 3 years, we should have closed these gaps Of course, we cannot come to 0-0, but progressively we should be able to close the gaps in information, the gaps in service delivery. I also need to mention maybe that we have concluded our health sector development plan for the next 5 years. And reproductive health is very key, and the projection is that every financial year we shall be having 30% of the budget increment on that particular component. So we are safe.
All right. Well, I see Flavia noting down, so I'll just bring you into the conversation,
Okay,
Flavia.
so
do your
I
comments.
want to
And
thank
just,
Margaret for...
just to stop you just there for a bit, as we continue the conversation, do know that you can also be a part of the conversation later on. The phone call lines are just below on the screen, and we'll be able to get in your calls. You can be able to either ask the commissioner, if it is Flavia, if it is Margaret. We'll also be having a number of panelists later on. So Flavia, back to you.
So me, I want to think like the usual person, the community person. We already have 69% gap need on commodities for Kawempe. We have 34 for health center 3, and then also for health center 2 we have a gap. Yeah. So for me, the rationale is, I just ask myself, what the rationale for creating more health centers when even those available lack lots of services, lots of commodities? Why not supply these available centers to full capacity before we embark on expanding? Because even when we expand, we have seen expansion having increasing, but we don't see a commensurate kind of service delivery in that area. So thinking as a lay person, I would think that the centers that we do have, if they were given money, they were given funds, because I do recall in like 2018, a health center too was receiving 300,000 or 300 or 400 or 900 per quarter. So you ask yourself, if you are building another health center too, this one has only been getting that 900,000 for a quarter. What is going to happen? Because even the increment in the budget is not directly correlated to the
Needs.
Services and needs in this community. So sometimes it becomes difficult. It's just like the things of politics that are happening. Every other day you have parliamentarians. So that is another stretch. It's going to pull off money that probably could have been even going to health. So you're increasing the infrastructure without health workers, because even the health work, the human resources for health, most districts are operating below capacity. So why spread the infrastructure when even what is available is not sufficiently funded and facilitated?
Margaret, bring you into the conversation on the kitty and and the way she explains it.
Yes.
Yeah, the overburden.
I really want to build on what Flavia has just said, but also in the context of our policies. Recently, the Ministry of Health approved the updated, consolidated HIV prevention and treatment national guidelines. And one of the key changes in the national guidelines was that every mother who goes for antenatal care services is supposed to undergo, in the previous guidelines, it was dual testing for HIV and syphilis. But now it is testing for HIV, syphilis, and hepatitis B. But when I did thorough analysis of the needs against the funded laboratory supplies, among the key things which are also going to be affected, hepatitis B testing supplies, and also HIV testing supply, laboratory testing services. We also have cervical cancer. All these are fall under sexual and reproductive health. Cervical cancer screening supplies and other components which are really critical when we talk about accessing services. So, and also going back to what the commissioner said, I very much appreciate establishing more health center tools. But when I look at the wage, the allocation for the wage, it is stagnant. It is the same allocation that was there when we had fewer facilities, is the same allocation for the financial year when we are looking at more health facilities. And I'm thinking about what bullet magic are we going to use to make sure that we really sustain this. And this is coming at the point when even the budget allocation from the external financing, you know, we get a lot of support external, especially for sexual and reproductive health externally, but it has dropped. It's a huge difference. So how is the government going to meet that? I appreciate the fact that when I analyzed the MPS, I realized that the government is planning to come up with a domestic resources mobilization strategy, which is a very good initiative, but it is something in the plan. And I don't think that adolescent girls and young women, including other women, will wait until when we get those plans, we start mobilizing the resources and, you know, meet their needs. Meanwhile, we are getting more unintended pregnancies, and those unintended pregnancies are followed with abortion, and these abortions are not safe, but, you know, unsafe abortions with all its consequences. And so, to me, that creates a huge concern. And listening to the recently concluded JAR, having participated virtually, I was so shocked by the drop in services, in the access to services by the people living with HIV. And when we talk about SRH, the SRH needs of those who are living with HIV is even enormous because of their compromised immunity. I realized there was a reduction in ART initiation by 31% between December to date. That drop is so huge because if a mother is living with HIV and with challenges in accessing health facilities, with challenges that we have had, we could have ended up with some babies who were born with HIV because of not adhering to treatment. I also heard about viral load coverage having reduced so much, and also reduction in CD4 count access, reduction in accessing HIV testing services, because we have many Ugandans who do not know their HIV status. But majority of the mothers get to know their HIV status from the antenatal care clinics, because when they go there, then they will undergo the testing. But if we have this kind, then we are having a missed opportunity. And so that takes me back to looking critically at the allocation that under the Ministry of Health was for pharmacies and also and other supplies, including the national medical stores. If the budget remains stagnant and we are increasing health facilities, from the mathematical point of view, you see a mismatch.
Yes, when we talk about the mismatch, and I think each of you can answer this, just picturing what kind of quality population we shall have if we continue to go down this road, because this morning the conversation is implications that are as a result of access to sexual and reproductive health. So what particularly might look like our population? And I'll start with you, Flavia.
Thank you very much. Viewers, I think the population we are looking at is an increasing population of young people having babies, young people dropping out of school. And I'm not talking about the girls alone, because many times when the boys impregnate, they also are forced probably to marry these young girls or whoever it is they have impregnated. So the drop out from school is going to bring us catastrophic implications in terms of productivity, because once they drop out of school, it means they have reduced on the levels of exposure and getting more educated and getting more skills. So we shall continuously have a boom of a peasant community. I also think the other implication is that we continue to see a disgruntled community. You have seen people cutting others because they are not productive. And when they reach home and somebody is saying, where is the food, where is the school fees, we continue to see the gender-based violence that is happening across the country. And not because of COVID. COVID has only helped to amplify what is happening in the community. And we shall continue to see substandard and fake medication coming into the country because the government is not able to fulfill the needs, the public need. Pharmacies will start bringing in those ones which are not working. You can see on a high rate we have commodities that no longer change our ailments. You have been taking the commodity, but it no longer your disease doesn't respond to that. So I think what we see is that also that if you don't have serious and deliberate investment in human capital, those roads you are building, who is going to use the roads? If people are sick, if people are uneducated and you know they are not doing much to leave their hometowns to take commodities to sell, they are unwell generally. So for me, I would think that human development should be the fountain. Take education, take health, and ensure that these institutions or ministries and sectors are given a big chunk of money that helps to improve our health and livelihood so that we are productive. And then we are able to use the other infrastructure that is coming in. Yes.
Okay. Well, to you, Richard, let's take a look at now, when we take a look at the quality population, we're also looking at it in line with what load will the Ministry of Health have now if we don't at all be able to avail these services?
No, personally, I feel like we need to be hopeful because this is a country that has moved very far from where we came from. And we are registering positive impressions and progress. If you look at our mortality rates, both maternal and infant, how was it before? Two, if you look at also investments being done in health, education, and other sectors, you should appreciate.
We do.
Nevertheless, you should also understand that money does not do everything.
That's true.
Money does not do everything. We need to look at strategically what can we do differently. For example, we know that 70% of all the diseases we have here are preventable.
Yes, just to stop you there for a minute,
Yes.
Commissioner, let's just take in a call and continue with the conversation. Hello, good morning.
Hello, good morning.
Oh, good. Who are we speaking to and where are you calling in from?
I'm Charles calling from Oung.
Okay, yes. What is your comment or question and to who are you directing it?
Yeah, my comment is based on health users. Here in Oung, most local people blame the big local government as the people behind poor health systems in the villages, the parishes. But you see that most of the big local government does not have much authority, apart from soliciting for land that is given to build a health center. But you find that the health centers, when they are already instituted, they are placed in a specific place. There are no services completely. The only service that I see relatively is natural services. But all other services, they're not there. So you find that the health centers in the villages does not really help people much. People who are now helping our people in the villages here are mainly the private health centers, the private pharmacies, other people. That's where people are going to get their assistance from. Our government health centers are not helping us at all.
Okay.
Thank you very much.
Thank you so much. And I think that will be directed to you, Richard. After you finish your comment, you can go ahead and
Yeah, I was just saying that, of course, we need also to look at what other innovative ways of doing things. Primary health care is very, very important. So if our communities, if our homesteads, if our parents cannot help at the home ground, it becomes very difficult. Government cannot come in when you are unable to do the basic things. Washing hands, covering the toilet, having a toilet is also a problem in some communities. So we need to be looking at those ones more critically before thinking of health centers. You should be coming to a health center when you are sick.
But you see, just to stop you there, Richard, if at all in one way or another, you say, yes, we should look at the community doing a few things for themselves before coming to government. In Oyam, we've just gotten a call from someone from Oyam who's mentioning that you see there are health centers there, but we end up going to the private health centers because we don't get treatment there.
Absolutely.
Yeah. So we're going to continue this conversation. Let's just take a call.
Governance issues.
Yes. Let's just take this call. Well, we seem to have lost it, but you can call us back on the numbers just right below the screen. But you mentioned that there are governance issues there.
Governance and leadership issues.
So who holds them accountable?
Like in local governments.
Yes. Well, we seem to have a call. Hello, good morning.
Hello?
Hello, good morning. Who are we speaking to and where are you calling us from?
Hello?
Well, we seem to have a network issue there. Do try and call us back on the number that is right below the screen. I asked, who do you think we should hold accountable at this point in time?
There are things which are under the local governments. Health centers, from Health Center 1, Health Center 2, Health Center 4, and district hospitals are under local governments. And that's their mandate. They have district health officers who must supervise, including the accounting officers. They have teams. So I think we need to be looking at, and he's very right. You'll find a government facility, people, there are no services, yet they get drugs, they are paid salaries, okay? It is even closed at times. But a PNFP, private not-for-profit, being managed by maybe a Catholic church or Protestant church or Orthodox, people are going there. So, but it is also the mandate of the people to demand their own rights.
And just as we wrap this
For us,
part
we
out,
are doing policy, but the monitoring part comes from the districts.
can we take a look at particular figures? When he mentioned the fact that people end up going to private clinics.
Yes.
Maybe a particular girl who might be 16, 17 finds out she's pregnant, and along the way she tries to get an abortion. Now the statistics stand that 47% of about 200,000, 97,000 unsafe abortions annually among girls aged between 15 to 24. If a government in one way or another, although we say it's something to do with governance, is not able to help this girl, this is where she ends up, in these quirky little clinics where they lose their lives or where they carry out these unsafe abortions that eventually impact their health later on. So taking a look at such implications, that if at all the government doesn't do something, you push them into the wrong people's hands. Yeah.
Maybe.
Yes, Margaret.
Maybe to say something about primary health care. I think what is important is that we should know that primary health care is also packed. We need to unpack it. It's beyond, for instance, saying that wash your hands, you know. TB, HIV, access to those services all fall under primary health care and other interventions. But looking at the budget, because to me, when we talk about commitment to something, it comes with the resources. If I say that I want to do this and I don't commit resources towards it, it means that my commitment towards it is very minimal. Considering the previous financial year and comparing the previous financial year and the current one, we also see a reduction in the allocation for primary health care. And that is an area where we need to put a lot of emphasis, especially if we are saying that we want to achieve universal health coverage. Because when we talk about universal health coverage, we need to look critically at three things. We need to look at population coverage, we need to look at geographical coverage, but we also need to look at financial coverage, the cost coverage. Are the young people financially able to access the services? Because if someone in Kampala can access the services, how about that person who is in the hard to reach area who has access to health center 2, but the health center 2 does not have the services that she or he needs? I think we need to go beyond.
So I just wanted to say that then we have a problem. Because if what has changed, when I grew up, we had the mutongole, the parish person coming to our homes and checking, do you have a toilet, do you have, you know, and it's difficult to make everyone have a toilet and whatever you want. But I think it's government role or the system to ensure that people have things in place. But then we also talk about the expansion of these districts. Already people are operating below capacity. So you're going to overstretch the same person to even go to do surveillance. But do they even have the money to do the surveillance that is required to ensure that these health centers, these communities are doing whatever they're supposed to do? Do they have enough to educate the public about sanitation, about hygiene, about access to services, what is available, what is, you know, people don't know. It's just, you know, we had VHTs at one time, but these days they have also become, what should I say? They have been demobilized because maybe there are no commodities they were serving. They try to educate the communities, but of course they also need to continually be refreshed.
That's
so with the
true.
expansion of health centers and you know, the administrative units, are we sure we are going even to make a difference despite the 30% annual increment?
That's the questions that
budget,
those are questions that we definitely continue to have in this conversation. Now, at this point in time, we're going to be taking a short break, but right now in the first hour, we've been having a conversation about what the trends look like and how they're in one way or another informing the implications when it comes to access of sexual and reproductive health and services within the country. As joined by Margaret Happy, she is a consultant, budget and policy consultant here in the country. Also joined by Ms. Flavia Chomukama, who is the executive director at AGA, and also joined by Mr. Richard Kabagambe, who is the Assistant Commissioner in charge of Budget and Health Financing at Ministry of Health. Now we're going to be taking a short break, but when we come back, we now take a look at what perhaps needs to be done. What are the solutions? Because when it comes to a recently winded up study called Adding It Up, the findings revealed that just a little additional investment in reproductive health and care would end up saving costs for the country. So what solutions do we need? We'll be taking a look at those with some other panelists when we come back. Thank you for staying with us on NTV. Now, we're still having a conversation about the implications of access to sexual and reproductive health and rights within the country for young people. We've just had a conversation where we had a commissioner from the Ministry of Health. We also had the executive director from AGA and also a budget and policy analyst in the country. But now we take a look at the solutions to what has been discovered, the problem that has only been magnified during the COVID-19 pandemic within our country. Joining me to have that conversation, I am joined by Mr. Muhumza Abdul Karim, who is the Program Officer, Partnership Center for Health, Human Rights and Development in the country. Welcome.
Very much.
Also joined by Ruth Awori, Project Coordinator, Uganda Network of Young People Living with HIV and AIDS. You're welcome.
Thank you.
And also Mr. Robert Ochaya, who is the National Coordinator Right Here, Right Now, the Uganda platform. Good afternoon to all of you.
Thank you.
We'll now get into, because from what I know about the three of you, you get to engage with the youth on a day-to-day basis. What are the issues that the youth are particularly concerned about when it comes to access of sexual and reproductive health and rights services within the country? We'll start with the lady, Ruth.
Thank you very much. So being that I'm a young person, it gives me a greater leverage and talking from a lived experience of a young person and access to SRH services. So when you look at the services, I've had the person from the ministry talk about the availability, but you forget about the need for the information to aid the accessibility, the utilization, but also the use of the services properly by the young people. On different occasions, more so, which was magnified, just like you said, during the COVID-19 pandemic, young people were cut off from accessing information. They had to take up to the online spaces, whereby there is no guarantee that every young person has a smart gadget or they have access to internet so as they can access the information on internet. And then the other thing that is limiting access to services and utilization is the absence of the youth-friendly services. There is one thing of availing the services and there is another thing of making the services youth-friendly. Madam Flavia mentioned it, you can find a young person going to a facility, maybe they're pregnant, But when they reach the facility, there is this judgmental nature of the health workers there. And that's why we look at strengthening the peer-to-peer service delivery model, because we understand that even though the service is available, unless they are made youth-friendly, the young person will run away from the facility or not come for the services as well. But then also, there is a question mark on other people aware of these services. Because there is one thing putting them in the facility and the young person knowing that if I want a condom, I can go to this facility and get a condom. And there is another thing also that we need to focus on, ensuring that as we provide this information, we provide it in its rightfulness. Not restricting it, but also ensuring that it's age appropriate, as we have always been guided. Because on different occasions, you'll find that a young person maybe has been raped, but they don't know that if I go to a facility, I can actually be given PEP and I can be protected from contracting HIV. But these services are there, the young people are not aware of the services. And in some cases, more so during the COVID-19 period, we were notified of a situation where there were drug stockouts, like absence of the drugs for people living with HIV, more so for young people on the second regimen of treatment. So when they go to the facility, they have reached out, they need this treatment for their lives. As you know, ART or antiretroviral treatment is a lifelong treatment. Unless one is on it, they are bound to face a lot of challenges and side effects if they go off the treatment. But here comes a scenario, for example, in Kabong, where young people had to go for over 2 weeks without treatment. So it poses a great challenge to strengthen or to increase access and utilization of these services by the young people, when in actual sense there are a lot and a number of barriers to the utilization of the services.
Okay, and over to Muhumuza, when Ruth mentions the fact that this information, the availability of this information to the youth, it also begs the conversation, are other conversations being had with the youth about things such as sexual and reproductive health? Are they even being spoken about?
Yeah, thank you, moderator. Yeah, the issues of the youth, and I think when you look at the current environment, most of the challenges the youth have had is that, the government has put in place certain platforms and spaces where the youth can be able to engage and share their SRHR needs and concerns. But we still have a challenge where, for instance, the policy environment has not enabled the youth to really have access to this information adequately, appropriately, but also the services. So you find that, for instance, most of the policies, recently the Ministry of Education, the National Sexuality Education Framework, it was released, but after challenging government on issues of access to comprehensive sexuality education to the young people, which really enables them to grow up when they're well informed, when they can have consent on accessing services, but when also they are able to make informed decisions on their health and well-being. So the youth have not been really engaged so much in the various spaces in decision-making. Yes, at the grassroots, you find they are doing a lot of dialogues, they're engaging the policymakers, but then when it reaches the aspect of decision-making, we don't see the issue of the youth being prioritized. And I think that's where the challenge is. And you know that this country is a very youthful country. And you see the growing populations among the youth and the many challenges they're having. Because currently we are still at 25% of teenage pregnancies. We have classical districts where we have very prominent leaders in this country. But their areas, their constituencies are having huge challenges of very many teenage pregnancies. We are seeing young mothers as early as 9 bearing babies. So I think the issues of the youth have not been prioritized by this government, and we think they need to involve the youth more. We need to look at meaningful youth participation in policy formulation, but also in terms of access to information and services. So we think the government has a big role, however much it involves other many stakeholders. We have so many policies, for instance, in place which are not yet finalized. The school health policy, we should be informing how the youth can be able to access health information in the schools. You have issues of the adolescent health policy. It is not in place. All these are the RIA process, regional impact assessment. So we think the government really has a big role in ensuring that these policies, first of all, are in place, but they are informed by the youth issues, not sitting at the ministry, not looking at the youth and say, these ones are having these challenges, let's incorporate them. So it takes time to really have the youth on the table and involve them in decision making. That we shall be able to address their issues.
Okay, well, I see
thinking
Robert
on their behalf.
I see Robert nodding his head and saying yes, 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 and that perhaps is informed by your conversations with the youth. And what are the youth saying when it comes to the policies that Abdul Karim has highlighted?
Yeah, thank you very much. We interface with the youth, but also with the service providers. And we get a lot of concerns from the youth and especially young people. They share with us that when they go to facilities to access certain services, they are denied because they are young. For example, if a person aged 15 and below, despite being maybe sexually active already, ask for family planning, of course no one will listen to such a person. Of course, young people also need to practice safe sex behavior. And then you find that despite Uganda, being part of a lot of international documents and agreements like the SDG, the ESA commitments and all that, which mandates the country to provide, information on sexual reproductive health and rights, as well as services to young people. And also to avail even family planning services to young people. The country signs up, but implementation is still a challenge. Going down, these policies at global level need to be, brought down and localized to our national policy. But you find that for Uganda, revisions of policies take forever. For example, Karim mentioned about the school health policy. This policy has been in draft for 18 years, the last 18 years. And you know what holds it back? Simple things. We disagree about small things like, what is the age a person can accept contraception? Or what is the age you can start talking to a young person about, sexuality, about growing up. And these are really minor things that if we love our young people, we need not to hold such information from them, because young people are not homogeneous. We have young people living in slums and are exposed to different challenges. We have young people, living in remote areas and rural areas who cannot access information as easily as those in the upscale, areas. So we need to be cognizant, or policymakers need to be cognizant of the fact that, burying our head down on the ground and denying that, some young people need this information and some young people need these services will not help us. Look at there's the school health policy that we have, the National Adolescent Health Policy that we have. That is a version of 2.14. And in this world, things are changing very rapidly. The challenges that young people are facing cannot remain the same. The challenges that we faced in 2004 are no longer the challenges that people face today. Look at COVID. It came with a lot of challenges. Every day, when you look at the news, you see, teenage pregnancies are rising up. Abuses of young girls are rising up. And what are we doing to help these young girls? Do we just say we write them off and forget? Now, if a young girl unintentionally becomes pregnant, is there a way to help this young person? Do you have a policy for readmission in school, for example, after the girl has delivered? What if the circumstances don't really allow such a young girl to actually deliver? Do we have policies that support such a young person to access, maybe safe abortion that will not put her life at risk? And also when you look at this denial, it's costing the government a lot, because we are denying that, young people are not sexually active, but they are becoming pregnant. How do they get pregnant? The answer everybody knows. Now, when they get pregnancies, they go and seek, unsafe abortion. And when they seek this unsafe abortion, complications come up. Government has to now offer post-abortion care. And we end up spending a lot on such things. Yet government could actually prevent this from occurring by, putting in place conducive environment that provides this young person with information to prevent this kind of unwanted pregnancy or any, risky sexual behaviors. And this, we see that not enough is being done.
Well, as we highlight the problem, also one of the things is, and many do not want to talk about is that our country is a very conservative country. A few things such as telling a child of 15 that, well, there's this contraceptive that you can use is something unheard of. In some families, a child even turns 19 and the sexual conversation has not been had. The guidance of that brother of yours, you need to be very careful. So taking a look at the society that we live in, vis-a-vis what you are asking, a conversation, and even when you say some frameworks have not been able to be implemented, why? Because of the society. So if some of these youth, I believe, don't even have these conversations with their parents when it comes to, well, I am actually sexually active. And to each of you, I'm going to ask you to how it has been when it comes to, I don't know if you have interacted with the parents, if at all you get a chance, of what you hear from the youth and what they say about just even having that conversation. But as we get into it, do know you can be a part of the conversation. The hashtag is at the bottom of the screen, and so is the number that you can be able to call in later on and share with us what you think, but possible solutions to the problem that we face right now in the country, and also any question that you might have that could be answered. So let's go back to the conversation. Conservative society that we have, and how the youth are able to talk to their parents. From you, Ruth?
I'll start from where Robert stopped, and I'll agree with him that we are shying away from the reality, but we are getting ashamed in the process. When you look at the situation that we are in, I don't know why we have to again go back and start programming for abortion, when in actual sense we could have avoided this by allowing these young people to access the SRH services, including contraceptives. So in actual sense, in our communities, I'll agree, they are conservative, because this is not something that a parent will feel comfortable to tell a child that this is like this and this and this. When you're ready to have sex, you should use a condom. And this is why we are always lobbying for the peer-to-peer service delivery model, because we know that a parent may be shy to tell a young person, but this young person talks to her fellows or his fellows in the community, at the schools, in the churches, at the village, in the different occasions that they engage in. Because it's going to take us really long to get it accepted in the different communities, as we know that Uganda is a faith-based country, and then they will listen too much to the religion teaching, the religious teachings, and you know the Bible says this and this and this, so the Quran says this and this and this. So it's really going to take us really long. And though we are trying, we appreciate the different efforts to try and change these perspectives. However, as we still focus on changing the perspectives of these people, let's use the different mediums that we have. We have the online spaces, we have the different activities in which we engage the young people. However, we appreciate that, I'll take an example of SEHAD. They have done different activities like VCATs to transform the people's attitudes and values, and this is really yielding results. But as we continue that and to try and achieve those results, I'll still emphasize the need to strengthen the peer-to-peer model, because this has been working out in different communities, be it in access of services. I'll take an example of during just the COVID-19 period. Young people distributed over 27,000 condoms. Who are they giving them to? But these young people could not reach out to the community or to the health worker at the facility. But because they know that when I reach out to a fellow young person, he or she will not judge me, it's easier to interact with their fellows and access the services.
But don't you think in one way or another it is sort of watered down if we don't have the entire society on board for this? If you just have only the peers, but we have parents who are saying something totally different and not even choosing to talk about it, in one way or another, doesn't it hinder the progress made there?
When we are doing advocacy, there is what we call opposition mapping. And in the due process, we identify who are these people that we need on our side, but they are on the other side. And then we try to always engage them. I'll declare that some parents have transformed and they're already champions, and we're already working with them. We have pastors who are working with, I'll take an example of Reverend Canon Gideon. He's a reverend, but he acknowledges the fact that these young people are out there and they need this information. So I'm not saying that we should work in isolation with peers. That's really not true, because advocacy is a collective effort and we need to work with every party in the community. So as we still go on and continue, we should also be able to identify and work with our allies. That's also key. In this case, so for the allies, we have other young people who are already being champions and other key stakeholders who are already out there and supporting the kind of work that we do.
Okay. To you, Muhumuza, on that note?
Yes, thank you very much. I want to entirely agree with you and also Ruth about the conservativeness of our societies. And you agree with me that really, even when still we've had very numerous scenarios over social media, all over the places in communities, but we've still remained conservative. So we've ignored that really these issues are happening to the youth. When you look at the statistics, they really cause an alarm. They indicate that we need to do something as parents, as policymakers, but also the communities. Because if you continue denying the youth the information that they deserve to get, they're going to continue making mistakes. They're going to continue doing things which they think are right, but because of the pressure, they end up into very many challenging situations. Issues of teenage pregnancies, issues of unsafe abortions, and other many complications. And then the recent speaker, the commissioner, mentioned about the issue of the government putting in very many measures to really mitigate these issues. But the component of health promotion is very key in advancing sexual reproductive health and rights for the young people. These youth need information. They need access to information. You talk about the role of parents. Yes, parents have a role to nurture their children. But you see, in the societies we live, they are guided by the norms, by the culture, the religion, the backgrounds. That's the background we have. And we say the church cannot allow a young child of this to speak about this kind of information. But we forget that things are happening. We've had social media where I saw a challenging video whereby two brothers were engaging with a sister. You can imagine such a scenario. So I think we need to come out as parents, we need to come out as policymakers and ensure that these children access information. The parents spend some time with parents, but schools, this is where we talk about the policies, school health policy and the likes, adolescent health policy. The children are going to spend all the time with parents, but when they leave their homes, on the way, they face challenges. At school, they face challenges. So we need to have that multi-sectoral approach whereby at various levels, we really support the young people to access the right information so that they can make informed decisions. Because at the end of it all, when they get these challenges, the effects come back to us as parents, as policymakers. The government will keep spending a lot of money on managing complications due to unsafe abortions. The government keeps spending money due to complications of these teenage pregnancies. So why can't we put in efforts on health promotion, on preventive measures, than waiting for these catastrophes? Okay. So I think we need a multi-sectoral approach.
All right, Robert?
Yeah, thank you very much. I totally agree that we live in a very conservative society. And as advocates, we are also trying to do something to bring about common consensus. For example, we realize that some people are opposed to, for example, SRHR or sexuality education, not because they want to, but because they lack information. So we've particularly targeted certain very important stakeholders by way of, educating them or sensitizing them on what actually is meant by, for example, sexuality education. Because, for example, most people, when they just hear the word sex, they assume that we are teaching young people, bad manners and things related to the actual or the physical act of sex. But this is not the case. So a lot of times when we engage with the different groups of people, especially like certain religious groups or parents or even journalists, name them, when we unpack what these concepts actually mean, a lot of them begin to understand and begin to soften their stance on these kind of issues. We've also conducted a number of studies and opinion polls. And when we reached out to communities, a lot of parents actually support, provision of sexuality education. We are disagreeing about small things. When do you start? Do you start as early as 6, or do you need to wait maybe up to 12? We're also disagreeing about small things like, if you are talking about a policy, for example, the sexuality education framework, why do you call it sexuality education? Call it a different name, maybe health education framework or something.
Wouldn't you be hiding a few contents of it?
Yeah, so that those opposed will not be that opposed. But of course, when you are now unpacking the contents inside there, you put age-appropriate content, different for different specific groups. And I think that is what we are working towards in order to build consensus, reduce, resistance. And also, we need to realize that Uganda is a value-based society. We have cultural values, we have religious values, and we have, personal values. In advocating for policies that help young people improve their, sexuality and all this, we don't need to ignore these values. We need to take into consideration what values the religious people hold that are so dear, and we need to take into consideration what cultural values. We need to respect this, but not at the expense of the young persons. When you weigh, values and youth and your child, who is more important? And we know that values and practices change over time. We've called upon, different stakeholders to change, to adjust, to move with the world, because the way we were helped 3-5 years ago cannot be the same way that we can be helped this year. We used to have aunties or uncles who used to take us to the banana plantations, talk to us. Now there's no time for that. Children are in school. How do you help the teacher, better support your child? When they go to a medical facility, how do you help the health service provider better serve your child? A lot of times when young people go there, the health workers are limited by certain, policies and laws. For example, we have the Penal Code Act. So when a young person who is different from the others, you know that also that we are not the same in this country. Talk about issues of inclusivity. We have a young person who is feeling differently from others, and he goes to a health facility. Immediately, outrightly, that person is chased away, without even trying to listen to them. But these people are part of the society. They need to be helped to also stay healthy and also stay alive.
Okay, now earlier on, Muhumuza had mentioned the fact that there are leaders who know about these things happening in different districts. There are particular districts where, in that one, teenage pregnancies are at a high there. And bringing in leaders into it, we have talked about the religious leaders, Robert has mentioned them, but taking a look at if we have the leaders on board, understanding where we are at this point in time when it comes to sexual and reproductive health and rights services in the country, perhaps the policies will be informed a little bit faster, the frameworks will change where they need to change. So is there engagement with leaders in your different platforms? Start with you, Ruth. Have you spoken to leaders? Are leaders interested in being able to help Uganda network of young people living with HIV and AIDS and all the other youth that you talk to?
I'll say yes, because on different occasions as we do the different engagements and activities, we always look out for the different stakeholders who are in positions of influence, who are in positions of decision making, and so are the leaders as well. And from the different occasions and engagements that we've had with them, there is the will to change and support the kind of work we do. I'll take an example of the districts like in the eastern region, whereby they are supporting young people even to be on the district aid committee so that they can easily push for the needs of the young people. And we've also had different people who are becoming champions for the kind of work that we do in the different districts as well. So I'll still confirm and say the leaders are willing to support. However, there is sometimes the competing priorities, I should say, competing priorities. Now, like in this situation of COVID-19, you can't come and start being like, there is no condom at the facility when they are looking at masks. However, with the continuous when we make these people our allies and make them understand the need and the reason as to why we need these services at the facility, there is always that commitment and the vigor to always support and see how they can help out in their different capacities.
Okay, so the will, but then the willpower and the priorities is the issue. Yes. Is it the same for you, Muhumuza?
Yes, we've really overly engaged the leaders at different levels. For instance, to mention is that over the years we've engaged different cultural institutions across the country. By the way, you find it interesting that at the cultural aspects, you'll find they are very open to these discussions because they know the different challenges their young people pass through. But also the challenge is mainly at the policy level and the level of the legislators. Because you'll find that most of the challenges which we are having currently today, which are hindering the youth from accessing information on these services, some of them are attributed by our policy environment and the legal environment. And we think if these policies were really prioritized by the government and the respective ministries, and they are put in place, but also considering sexual reproductive health and rights, there will then be a basis. They will provide guidelines on how these young people can access information. So we've overly engaged the duty bearers, even to the level of police, we've done a lot of values clarification and active transformation exercises with different policymakers. But then we still have a challenge whereby there will be an issue that will come up. When a policy comes up, it has been launched, and the next day you'll hear this policy has been recalled. On what grounds? The Interreligious Council Board said there are issues A, B, and C, D, which they don't agree to. They look at the values of the country. So I think we need to look beyond the values. We need to look beyond our offices, our seats, our opinions, and look at the actual issues affecting the young people. If you are seeing more teenage pregnancies each year increasing, then you raise a question. What aren't we doing right as a policymaker, as a parent, as a leader? If you see unsafe abortions increasing in communities, then that should raise or ring a bell that something is not being done right. So I think many efforts have been done, and I think we want to call upon the duty bearers, the leaders at all levels, be it at community level, be it at the policy level, and the level of legislators. They need to really respond to these issues. They need to stop from shunning away from these issues. By the way, interesting, these issues are happening even in their own families. We have scenarios whereby we've engaged with young people from very respectful families, but they have challenges, and they can't talk to their parents, they can't approach their leaders, but they are suffering these issues. But because some people are big there, they hold on to these kind of policies, they hold on to these processes that really they are kind of delayed, and we don't, at the end of the day, materialize the issue of addressing the challenges of young people. So I think we need to really, the efforts have been done, but we need also the duty bearers, the policymakers really to act. We appreciate the efforts made. Very many policies have now been pushed a bit, because most of them are being now at a regulatory impact assessment, but we don't need to stop at that. Let us have them finalized, and let us have them implemented, because the issues affecting the young people are the issues even affecting this country. The more we get these challenges of teenage pregnancies, the more we get high rates of maternal mortality, we are going to spend more as a country. And we are going to keep on saying that the health sector is not having enough funds. We are going to keep on saying, but while we are not investing much into health promotion and health education to prevent some of these issues which are coming up.
Okay. Well, Robert, we're going to be getting your thoughts on leadership, but do know that you can be a part of the conversation, whether you have a comment, whether you have a solution or a question. The numbers are right below the screen, and also the hashtag on social media is right on the screen. We'll be getting into your thoughts. All you have to do is give us a call. Robert, your thoughts on leadership?
Yeah, thank you very much. We very much appreciate the role of the different leaders, and we actually try as much as possible to consult and dialogue and inform different leaders. But sometimes we are faced with bureaucracy. The right persons that you need to speak to might not be easily accessible. So you end up speaking to someone who will speak to someone, then who will speak to the other person. But you know, information is better delivered like when you do it physically. So we call upon, you know, actors in public spaces, in public offices. You are our servants. You need to avail yourselves to us. Let us dialogue in order to help our young people. And this include, you know, people in political offices, and people in, you know, who lead religious groups, and people who lead cultural groups. When we invite certain sections of leaders, sometimes they shun our invitation.
We might get into the reason why they shun. Let's first take this call. Hello, good afternoon. We seem to have lost it. You can call us back. The number is right below the screen, and we'll take your call. Now, when you mentioned that these people shun, let's just take this call once again. Hello, good afternoon.
How are you?
I'm fine. Who are we speaking to?
I'm called Joseph Kauchi. I'm so glad to be part of this.
This is amazing. Where are you calling us from, Joseph?
My issue here is that most of the people that are happening to be supposed to be helping the community are actually not helping the community. You see, you find out that in certain places where medicine or condoms or things that are supposed to be helping these people in the groups and where they are not there. So we find the problem that other kids in the community is going to base on the resources that we have seen access to, but these people don't have them. So we call upon the people that are supposed to be working in those sectors of those things to be available. People are there, but they are not available. people are supposed to be in offices, but you go to offices and they are not there. So if you took on the responsibility of being a social worker or someone in that particular office, please take it on as your job, as something you need to do, so that when people come to access the information that you are supposed to give out to them, they will. Thank you so much for this talk show. It is very, very productive.
Thank you very much, Joseph. I don't know if any of you would like to respond to Joseph's comment or agree or disagree.
I'll agree with him because on different occasions, one of the reasons that's why young people sometimes don't access the services is because when they reach to the facility, sometimes it's the long queues and they're supposed to get the treatment or the service from a person who is very busy or at times not available. So it kind of hinders the accessibility of the services for the young people as well. When I come to a facility and I find that the health worker is not around or the counselor is not around, it limits it even demotivates, because even the next time I'll think of going to the same facility, I'll be like, the other time that I went there, no one was around, so why should I go there the next time as well?
Okay, well, we'll take in this other call. Hello, good afternoon. Hello, good afternoon. Well, we've lost you, but you can call us on the number that's right below the screen and we'll get into your thoughts on whatever. If it's a solution that you have in mind for the young people, if it is a comment or a question, we'll be taking those. Now, Robert, just back to what you mentioned about how leaders shun any calls that you, maybe invitations that you give them. Why do they shun them?
Yeah, thank you very much. I think I'm not saying that all leaders shun our invitations, but some of them.
Yeah.
And I think there are a lot of reasons for this. Some maybe are guided by, norms and values that they hold. So like when you say we're going to talk about young people's health or sexuality, automatically they will say that is not a subject that they're interested in. But I also think we as civil society are not doing enough to gather or garner public support. For politicians, for them to take your issues seriously, the voters, the population must put some kind of pressure on them. And so we think that it's also important for parents who are out there and members of the community who are out there, who are listening to us and are interested in these issues, to talk to their leaders, talk to the person that you send to parliament, talk to the person you send to the local council, emphasize the importance of these issues. We think that when, the communities express the need for some of these changes to be effected, then the leaders will start listening. And this is especially true for political leaders.
Okay.
But for the technocrats, I want to give them kudos. They've been there and they understand these issues, but they're limited by, certain bureaucracies. And that's why the movement is so slow.
Okay. Well, let's take in this call. Hello, good afternoon.
Hello.
Who are we speaking to and where are you calling us from?
I wanted to talk to the panelists.
To the?
Panelists.
Panelists, yes, go ahead.
Good afternoon.
Good afternoon.
I think I'm talking to the panelists of NPS.
Of NTV.
The panelists of NTV.
Yes.
Now, mine, I'm okay from Kenya. Mine is that for long, actually, government has not taken up with the program of the youth. Even as you earlier on had the other panelists about PhD. Those things are in paper. I was a health inspector at some 7 years. I retired in 2013. But I'm now seeing the challenges have multiplied, I think, 20 times. Because sincerely, there is no access to information, to services, and therefore the issues of youth are not being addressed totally. And the government is actually trying to deny it. The services are not there. The funding is very little. Thank you. I'm Okia from Bukedea, retired health inspector.
Thank you so much, Okia from Bukedea. Panelists, who would like to take Okia's thoughts?
Yeah, I think I totally agree with all the points that he has raised. And this also brings me back to some of the reasons that we think the policies are delaying. For example, you find that you review a policy, every approval is granted.
Robert, just to stop you there, let's just take in this call due to time and then we can answer all of them at once. Okay. Hello, good afternoon. Hello, good afternoon. Well, let's just proceed, Robert. We can go
Yeah,
ahead.
so I was saying that, some of the policies are being held back by lack of funding. You find that you have reviewed a policy, you followed all the processes, but, for you to get the certificate of financial implication, clearly stipulating where the funding for the policy will come from is a challenge. And so government sits back, they are scared of, whether, they're going to be able to fund this policy or not. And yet, in this space of delay, young people are continuing to experience challenges and suffer.
Hello, good afternoon. You're live on NTV.
Yes, please. Good afternoon.
Who are we speaking to? Where are you calling from?
Yes, speaking to SRHR.
Yes. Could you be able to just turn down the volume of your television set, please? Yes. Could you just turn down the volume of your television set?
All right.
Thank you.
You're speaking to SRHR from Uganda district.
What's your comment, question, or solution this afternoon?
I've been listening to your talk show, and I think what Mr. Muhumuza was saying is what I do support. There are many students or children at home there, even in rich families, but reaching their information is not easy. When they get problems, they just sleep on their problems, and those problems end up becoming or like increasing. So I think my thought is it could be better we get like the for whom young children can read, so that their voices can be uplifted.
Okay. Thank you so much. I think she pulls in the media on this one, having the media part of it, and perhaps we'll get into that part. But just, Robert, if you could wind up with a comment you were making in terms of services not being there, funding not being there, and what happens in the end.
Yeah, I think government should take, these issues, especially of adolescent health, as seriously as it takes the other issues. Like Muhumuza said, Uganda is largely a young population. We need to strategically invest in young people's sexual reproductive health if we are to be able to achieve the demographic dividend that we are all looking for. Because, in a population where over 75% are under the age of 35, where else do you need to put in your effort? If you don't, you are leaving the bigger, proportion of the population. And that is the future of this country. So whatever little that we have, I think prioritization should be also given to health issues, especially those that affect the young people.
Okay. Now bringing in the media as the young lady who had just called in, and perhaps we'll start with you, Ruth. Ruth, you mentioned just peer-to-peer is a way to help with this problem. But also another could be what messages are being broadcasted, not just only on television and radio, because we have social media where the youth are really picking all their thoughts from. What is the trend is there. How do we get the trend to be on social media when it comes to access of sexual and reproductive health and rights in the country?
One of the things that we took on were more so when we were put in the situation of the lockdown and not reaching out to the young people was use of social media and working with the media personnel. So one of the things that we would look out for is definitely the support from the media platforms, because in some cases you'll find that I talked about opposition, and in some cases you'll find that it's the media that is pulling down the kind of work that you're doing. I'll not say that all media people, but in some cases there have been the people that are pulling it down. You talk about sexuality education and they'll be like, the consortium wants to teach children how to have sex. So it's all about trying to understand what the concept is, just like Robert said. In most cases, when you try to understand what the concept is and what it's aimed at, it's when you will appreciate the whole concept. So as we continue to use the media platforms, I'll agree with you that as the population is really young, one of the places that they usually spend most of the time is social media, and we cannot control the consumption of the information that they have. And this is one of the reasons as to why, as a network, we came up with an online app that we use to disseminate information, and this is an app that is accessible for young people online. And besides that, we are looking at how best can we engage the different parties? How best can we engage the people from TV, from radio? And that's why we are using different platforms. Just like today, we are here trying to give out information on TV. We know that some people may not be able to have a TV set at home. There are other people on radio, there are other people on Facebook pushing the event as well. So we are looking at utilizing the different platforms, media platforms, and all the necessary avenues in which we can reach the young people with the information. But still, even though we had gone away from it, I would like to first go back to what the caller talked about funding. I was looking at the need for the government to prioritize adolescent health services under its domestic financing, because we all agree that funders may be pulling out. We are growing to a state where funders are leaving the funding to the government. But if we realize that the domestic funding priorities are not inclusive of young people's services, then it's really scary of what the future holds for adolescent health in case funders pull out. And this also goes to them to encourage donors, the government to encourage donors to include adolescent health among their programs, and making it part of universal health coverage. Because when you look at the expenditure that young people use when they're accessing these services, it's at 41% compared to the 15% advised by WHO. This means that many young people will pull away from using the services simply because they cannot access it. However, if we make it part and parcel of the universal health coverage and it's accessible to different people in the different communities without exploiting or draining their pockets or funds as well, it's a way to go. And then it's also important that the government protects adolescent health from other priorities that are emerging, because trust me, other priorities are still coming, other epidemics are still coming, and other pandemics are still coming that need government attention. But what will happen if we always jump onto the new priority and forget adolescent health? This implies that all the milestones that we had achieved prior, all the achievements that we have got now, like young people are getting high viral loads, simply because during the lockdown, priority was put on the virus, on the new virus, and we forgot about HIV. So we need to protect the health and all the other needs that have already been there from the emerging ones, but as well striking the balance in the two.
Okay, now quickly moving on, another conversation that I just want us to all touch on due to time is abstinence. We're all talking about access to all these different services, but the conversation about abstinence is also something, and you've all mentioned values, the values that perhaps need to change here and there, but how do we retain these particular ones, saying, just telling the youth, and I don't know how the conversations usually go when it comes to abstinence and preaching, if you can, hold on, if you must, control your urges. I'll start with you, Muhumza.
Yes, thank you very much. When you talk about abstinence, I think abstinence is also hinged on information, access to information. So however much we shall keep preaching to the young people that please abstain, we need to know that for them to be able to abstain, we need to provide them with information, appropriate information, which will then enable them to make informed decisions. Among the informed decisions are those to abstain and delay the sex. And you know, when they delay the sex, they will have more time to attend their books, they'll have more time to grow up. But also, I think the role we need to play around ensuring that the young people can abstain from sex is availing them with information, appropriate information. Because if you keep running away from giving them information, trust me, you said social media. Social media is very good, but also can be bad on the other end. Social media today, if a parent cannot talk to a child, to a young person, they will go on the phone. They have smartphones. By the way, it is parents even providing these kids with smartphones. If they don't, there are small boyfriends who can provide them the phones. So they will access this information. If they want to engage in sexual intercourse, they'll do some Google and find out. So how do we then enable these young people to access the right information? Trust me, if you don't enable them to access information, they're going to keep on making wrong and uninformed decisions, which are going to make them end up in two very complicated situations, like we've been mentioning: teenage pregnancies, school dropouts, unsafe abortions, and eventually deaths. We have seen 17.6% of the maternal deaths annually. They are contributed to by the adolescents, just between 15 and 24. And it's not something to be happy about as this country. So let's ensure that the different duty bearers, the different stakeholders support the young people to access information. The ministries have taken steps, but we really want them to make more steps because they have the power. They're the decision makers. We've done our role as civil society. Even at the community level, people are pushing, but then we need also to have support. We need political will, but also need the communities also to support the young people to access information. If you do that, then you'll have to achieve the abstinence you're talking about. But still, when people reach reproductive age, they start engaging in sexual activity.
And
and
the
there's
body
no way you're
starts
going
to
to stop
speak.
them. Yes,
Yeah.
the body demands.
Okay.
But they need information to make right decisions for their well-being.
All right. You, Robert?
Yeah, thank you. My appeal to every young person is that abstinence is the surest way of prevention. Abstinence prevents unwanted pregnancies, prevents STIs, prevents you from, contracting HIV and others. So my appeal to them is that if they can, they should, because that's the surest way. But for those that cannot, they need to behave and act responsibly to protect themselves. Again, like Karim said, I think we need to provide information, and we need to make this official. We need to make this guided by policies. That's why when there was talk of the new curriculum and all this, we saw this as an opportunity to input issues around sexuality into the curriculum, and also to prepare the teachers, retool them, to equip them with the necessary skills to deliver this kind of information. And this should also go on to churches. Religious leaders, use the spaces you have, the young people that come to the churches, have small societies and all this, and be able to equip young people with information. Parents, don't shy away. Talk to your children. If you don't, no one else will do. Because look at COVID now. All children are home. No teacher will come to your home to talk to your child. So gather the courage, talk to your child. If you can't, seek support from somebody else who can help support you to deliver information.
All right. And lastly, with you, Ruth, just briefly talk about abstinence, and we call it.
I cannot agree any further or any more with the other panelists, because you realize that most times the first time a young person has sex, it's because of their inquisitivity, and it's all because they have been misled by the peers that when you don't have sex at this age, you'll be like this or like this. When you have sex, you're beautiful, you're grown up, that means you're being appreciated. So I'll agree with my other panelists that it's all about information sharing and the young person to know and when to make the informed decisions, because unless they have this information, they will be misled by the peers. We understand that sometimes peers have information that is sometimes not true, that is sometimes needs other information to cover it up or to beef it up and make it more acceptable. And unless we support the young people themselves with the information that they need at the different levels, I'll declare that there is no age that I'll say that it's the right age to start saying that you should abstain or you should start having sex, because you'll find that a young person who is 13 is positive, is pregnant. And it's simply because they had sex. So we may say that we shall not talk about the other services until they are like 16 or 15, but we are all from different communities and different scenarios happen. So we always preach the gospel of abstinence and abstinence and abstinence, because just like Robert said, it's the safest measure that you can have. And unless it's a compromised situation, like in cases of rape or in cases of defilement, we always advise young people to always abstain from having sex until they are ready.
Okay, well, thank you so much, Ruth. The conversation this morning and afternoon was taking a look at the implications on access to sexual and reproductive health and rights services for young people, and we also earlier took a look at the trends when it comes to financing from the financial year 2018, and also just taking a look at what is due, which is 2021. That was our conversation. The solution part of it, I was joined by Mr. Muhumuza Abdul Karim, the Program Officer, Partnership Center for Health, Human Rights and Development, and from the Uganda Network of Young People Living with HIV and AIDS, the project coordinator there, Ruth Awori, and Mr. Robert Ochaya, the national coordinator, Right Here, Right Now, Uganda platform. Thank you so much for joining us on NTV, and we hope that the information, you have learned a thing or two as you wait on the government to come on board. There's something you and I can do. That does it. We're now going to be taking a short break, but when we return, we'll be going into NTV at 1. Do keep it NTV.